Hello, I am Dr. Jennifer Yarden, the CEO and co-founder of Curewize. At Curewize, we aim to accelerate and advance the personalized treatment of cancers common to children, adolescents, and young adults. Our lead product is ProAll for the prognosis and monitoring of acute lymphoblastic leukemia patients. In acute lymphoblastic leukemia, malignant immature white blood cells continuously multiply and are overproduced in the bone marrow. These cells cause damage and death by crowding out red blood cells that carry oxygen to the body, white blood cells which defend against infection, and platelets which helps blood to clot. Patients suffer from a multitude of symptoms, including frequent infection, muscular weakness, easy bleeding, and bruising. There are around 48,000 new cases each year with a median age of 13 years. Currently, minimal residual disease tests, also known as MRD, are routinely used to help plan the treatment of ALL patients. MRD is performed by measuring the number of leukemic cells left in the bone marrow after starting treatment, with results available 2 to 11 weeks after diagnosis. Minimal residual disease tests are performed around 5 times in the first year and twice a year in the next 3 years. From the test results, physicians can decide to give patients either a standard or more intense treatment. Here's an example of a treatment protocol that incorporates MRD testing. Patients' treatment regimen lasts around 2 to 3 years. Notice the different phases of treatment: pre-phase, induction, induction consolidation, reinduction, and maintenance. Now take a look at the top. You have risk stratification. There is standard, intermediate, and high. And at reinduction, patients are given a different type of treatment, either the standard, intermediate, or highly intense treatment. Patients are treated differently in order to ensure the survival of high-risk patients and sparing the toxic effects of therapy from the low-risk patients. Around 75% of patients succumb to serious side effects, including secondary cancers, lung, heart, and liver damage, and shorter lifespan. At Schneider Children's Medical Center in Israel, there is a central lab that performs MRD tests for all of Israel. Medical and laboratory staff realize that a better predictive test is needed in order to more accurately assign ALL patients treatment. They came to this conclusion because of several factors. First of all, MRD results are only available after starting treatment. MRD is highly patient-specific and therefore laborious and costly and can take up to 16 days to perform. The patient's leukemic factor may change during the course of disease, which makes MRD monitoring capabilities less reliable. And sadly, around 30% of patients defined as non-high-risk MRD succumb to relapse. So Schneider Children's Medical Center chose to search for a better biomarker in microRNA, which act like small switches that turn off the production of certain proteins. These microRNA were found to play an important role in the suppression and progression of cancer. Schneider Children's Medical Center then proceeded to create the ProAll prototype by performing 3 different studies. The first study is a discovery study, where 48 bone marrow samples taken from patients at diagnosis were screened by 979 different microRNAs. The 2 microRNAs whose low levels associated with the worst prognostic factors were chosen for further development. The second study was for designing the biomarker. Here, Schneider were able to show that ProAll can predict which AL patients under the BFM protocol were more likely or less likely to succumb to relapse, and thus needed a standard or more intense treatment. The third study validated that ProAll can predict higher risk to relapse in another AL patient group treated by the DCOG protocol. In conclusion, patients with low levels of ProAll were more likely to relapse, thus needing more intense treatment, while patients with high levels of ProAll were less likely to relapse, thus needing standard treatment. Now Curewize will perform an additional retrospective trial in the US and Europe in order to receive regulatory approval, widespread acceptance, and to translate ProAll to clinical practice. Now let's compare Pro-Ol to minimal residual disease tests. MRD tests measure the proportion of leukemic cells left after starting treatment, with results available 2 to 11 weeks after diagnosis. MRD tests are patient-specific and therefore involve many stages, are laborious and costly. While Pro-Ol measures a proven tumor suppressor molecule, results are available at diagnosis, is a universal test that is relatively simple to perform, and therefore cost-effective. Furthermore, the technical implementation of MRD is complicated, and reliable and reproducible techniques for assessing MRD are lacking. While Pro-Ol is based on a straightforward, reliable, and reproducible technology. Most importantly, when we compare the performance of the two tests, we found that Pro-Ol is able to detect patients as being high risk, who were wrongly defined as non-high risk by MRD. Both Pro-Ol and MRD are independent predictors of relapse and can work synergistically. Interestingly, patients positive for Pro-Ol had twice a higher risk for relapse than patients positive for MRD. With a global addressable market of $250 million, I am inviting you to partner with Curewize to help physicians make more accurate treatment decisions. Not only will you benefit from your investment, but all other stakeholders will benefit as well. Physicians and hospitals gain from bringing forth positive patient outcomes while decreasing the burden of long-term side effects. Insurers gain from a more cost-effective predictive test that decreases healthcare costs. Laboratories will welcome this simple and straightforward test. Most importantly, young patients gain advanced personalized guided cancer treatments which will increase their chance of becoming healthy adults. Thank you for your attention.